So back to ventilating our baby and setting our inspiratory time and expiratory time. If I think about a normal neonatal ventilation rate for a babe I'm picking up at another facility and transporting here, what are we looking at? Somewhere between 30 and 40, right? So I would come over here and I would say an inspiratory, a respiratory rate of 30. It's the cycle of that respiratory rate of 30 is 2 seconds, because if you do 30 breaths in a minute in 60 seconds, every 2 seconds the ventilator should be giving a breath. Therefore, and I'm going to skip those first two columns, I would set my inspiratory time to 1.2 and my expiratory time to 0.8. See, that totals 2 seconds. And so that will give us our respiratory rate of 30. All right. And then if I wanted to fiddle around with my I/E ratio, I could move further out into this chart if I wanted a 1-to-1 I/E ratio. But typically you're going to work in this first column. All right, because you want to allow your patient to exhale as much as possible before inhaling all over again. So again, I'm going to remove these first two columns, or at least wipe them out until we get to a different chart. So I'm glad we caught that in the middle of a training video. How wonderful. Okay, so we're looking at our patient that wants the respiratory rate of 30. So again, I said I'm going to set my inspiratory time at 1.2. So right about there. And then I'm going to set my expiratory time at 0.5. And that probably sounds a little more like neonatal ventilation to those who are listening to this video. It is one full breath cycle being delivered every 2 seconds. And you can see that happening here with our patient. Okay. So now I'm ready to connect my patient to the ventilator right after I set our peak inspiratory pressure. So I'm thinking NICU babies, usually a peak inspiratory pressure, a good starting place is around 20. It's all going to be dependent upon what your neonatologist ordered. For our purposes, we're going to go with the peak inspiratory pressure of 22. Dr. Saeed, I hope you hear this, because that seems to be a favorite number for you lately when I've been in the NICU. So you can see me dialing it up until you see how with each breath, and I'm hitting on that hash mark there of right about 22. That's totally manometer driven, okay? Now, the more flow that I provide in this system is the more gas flow that's flowing through the system. So if the baby wants to take spontaneous breaths in between these rates of 30, he has fresh gas to breathe. So that's why I usually, personally, I set mine around the 6 mark. But I could still deliver that if I needed to conserve gas for any reason. Maybe somebody didn't check the Isolette like they were supposed to. I could dial that flow rate down super low. I'm still achieving my inspiratory pressure of 22. My baby's still getting ventilated. I like that little buffer myself of having a little bit of extra flow going through there. So I assure that the baby is receiving all the ventilatory support that we are giving. So our baby is set at 22 over 5. Was set at 22 over 5. There we go. A rate of 30 and 40%. Now something I want to show you about the circuit, and these are issues that can come up in the course of transport that can really throw you for a loop if you don't know what's happening. When we go back to our expiratory limb of the circuit, I'm going to play with this, it might make a noise. When we go back to the expiratory limb of the circuit, this little piece right here, and this is where any extra gas in the system, and certainly what the patient exhale, is exiting the system, and it's going past this little valve here. And this is a valve protection system in that it allows that gas to offload into the atmosphere. Now, things that happen in the course of the transport, depending upon the time of year, the transport nurse or RT might have their jackets with them because it's cold outside and the ambulances are cold. And we tend to throw those things up here on the Isolette. That's fine, but I need you guys to be aware that if the end of this is occluded by a jacket, a clipboard, a book, a supply bag, anything like that, and I'm going to ask you to go over and look at the manometer while I occlude this. You can hear that your ventilator is running. It sounds like your baby's ventilating, but you'll notice that the needle is holding steady. And that's because the pressure is not being allowed to offload from the system. So your baby's actually not being ventilated. And the ventilator is without alarms. Okay? So the important thing to learn here is be very aware of anything you're placing up here at the head of the baby and near the exhalation side of the circuit, and that there should always be eyes on the ventilator component of your circuit or very nearby and frequently checking that. And once I let go of that, sorry, up there, down there. Okay, so this is essentially the setup for a ventilator circuit. Everything else is just going along, pack them up, package them up, and bring them home. I'm going to give a cut and we'll switch over to this. Okay, now if we want to place our baby in CPAP mode, it would be the exact same setup that we have right here with our circuit, with the exception of we're going to switch this switch right here. CMV is controlled mandatory ventilation. That's ventilator mode, if you will. And then below it is CPAP. And I literally switch that switch. And if you look at the needle, it's dropped down to that 5 centimeters of water pressure, or continuous positive airway pressure, now that it's no longer a ventilator. In case you didn't know, PEEP and CPAP are so closely related. PEEP is positive end expiratory pressure. It means it's a pressure that you're exhaling against to keep you inflated, whereas CPAP is a continuous positive airway pressure, meaning that when you inhale, you get that whatever level of positive pressure, and when you exhale, you're exhaling against that same level of positive pressure. So very closely related. So when I switch the ventilator or the Draeger into CPAP mode, my needle's no longer moving. It's not cycling breaths at whatever interval. It's solely relying on this PEEP knob here, and I can turn it to 0 to give nothing, 5, 10, whatever we're going to deliver. Let's say we want our baby on a PEEP of 7 because I like odd numbers. And if you look at our bag over here or our ventilator lung right here, it is holding inflated at that PEEP of 7. If for any reason I was increasing it, you can see the balloon grow. That's me increasing PEEP, and then as I close it, the balloon shrinks. Okay, so less pressure, more pressure. To connect a baby to a RAM cannula, which is what we use for PEEP and CPAP, I would disconnect my baby, and I would reach into the respiratory bag of tricks for my pre-opened RAM cannula. And the RAM cannula is the device that we're going to use in transport to deliver both high flow and CPAP if necessary. The important thing to know is that the RAM cannula is designed to connect directly to this circuit right here. So I can connect him up right there and place my baby on that 7 of CPAP right there. Package him up, make sure you're set, and come on home back to resting. All right. The last component I want to show you is how to apply high flow or a nasal cannula in the course of transport. And again, we use this device right here. I'm going to use that same RAM cannula we just talked about to deliver CPAP to our patient, and I'm going to need an oxygen line. And coming off with the ventilator itself right here, which I'm pretty sure all of you guys are familiar with, is a flow meter. It has a black Christmas tree. We called them nipples in my last hospital, so do what you want with that. It has a black Christmas tree on it, and the dial for that flow meter is actually attached to it right here. And you can see it's off right now, and I can go 1/4 liter, 1/2 liter, 1 liter, all the way up to the 15 liters it takes to power an ambu bag or a neopuff, which I believe you guys are utilizing this to power your neopuffs. So if I want to place my baby on high flow or just a nasal cannula, and I'll tell you now the difference between high flow and a nasal cannula in a neonatal population isn't. Typically high flow is warm humidified oxygen, but I'll tell you oxygen, whether it's humidified or not, that runs at 2 liters, is 2 liters nasal cannula, whether it's humidified and warmed or not. High flow is a higher degree. So we're going to use that same RAM cannula to deliver high flow or nasal cannula to your baby. So I have my oxygen line coming out of here, but the oxygen line, you'll notice, does not connect to the RAM cannula. I could cram it in there, but that would be ugly and awkward and it would fall apart. In the RAM cannula package is an extra piece. It's right here. And when I open that extra piece, which I did earlier just to make sure I know, it has a piece that connects to the oxygen line and a piece that connects to the RAM cannula. And so now I can set my flow back here with this dial, and I can place it on my patient up here. So that's essentially the 3 big functions you're going to utilize the Draeger ventilator for in the course of transport. I wax a little romantic for the device because it is almost impossible to break. That's why it's lasted here for 20 years, and it's why it's been around for 30 or 35 years to the best of my knowledge.